السلام عليكم ورحمة الله وبركاته. نبدأ بسم الله إن شاء الله ال 43rd Libyan Cardiovascular webinar. معنا اليوم الدكتور محمد لبيدي. He's going to present Bradycardia and Pacemaker Troubleshooting. والإكسبرت بانل في معنا الدكتور خالد بوزقية، الدكتور ناصر مسماري، وأنا حنكون المودريتور يوسف الضرات. أهلا وسهلا بكم. حنبدو إن شاء الله توا مع الدكتور محمد. الدكتور محمد لبيدي he's an assistant professor of medicine في Southern Illinois University. دكتور محمد is a cardiac electrophysiology، ومشكور اليوم he's going to present one of the first EP, it's actually the first cardiac EP lecture series. طبعا هذه collaboration مع Libyan Cardiac Society، و this is also the 43rd Libyan Cardiovascular webinar series. دكتور محمد, the floor is yours. Let me give you a co-host so you can share your can you share, Dr. Mohammed, your PowerPoint presentation?
Yep.
I'm going to stop sharing, or you can go ahead. تمام.
السلام عليكم ورحمة الله. شكرا دكتور الضرات، وشكرا الأخوة، وشكرا على الانفيتيشن الذي تحدثوا في Libyan Society of Cardiologists، وإن شاء الله في استفادة من سلسلة المحاضرات هذه. Today I'm going to be talking about bradyarrhythmias or pacemaker therapy basics. We'll go over the basics and we'll try to touch on the troubleshooting of the common problems. These are very basics. يعني متأكد إن أغلبكم يعني كلكم فاهمين الموضوع هذا. Electricity start from the sinus node و conduct down to the AV node, and a critical part من the conduction system is the His bundle and the conduction system below the His. Problems with the conduction system below the His usually cause serious problems. EKG اللي نشوف فيه في 12 lead EKG is a summation of all these action potentials at different parts of the heart. لما الساينس نود fires, الساينس نود activate both atria وبعدين يصير contraction for the atrium, and the only way to reach the ventricle should be normally يعني في الوضع الطبيعي through the AV node. إذا كان ما فيش في issues في ال AV node, then the electricity cannot conduct inferiorly to the ventricles and go through the bundles. طبعا في exceptions للحالة هذه. For example يعني لو عندك accessory pathway, there's ways for conduction of electricity from the atrium to the ventricle. نحاول quickly cover the basics of sinus node dysfunction and AV block and the indication for pacemakers for both. The sinus node dysfunction, it's a group of diseases. And the issue is in impulse formation. يعني المشكلة في صناعة electricity خلال داخل الساينس نود or انتشار atrial activity في الاتريا. البيسميكر منظم ضربات القلب indicated إذا كان عندك sinus node dysfunction unreversible. وفي العادة أنت محتاج أن يكون البيشنت symptomatic، يعني عنده symptoms واضحات related to the sinus node dysfunction. هي زي ما قلت a group of diseases includes symptomatic sinus bradycardia, sinus pauses or sinus arrest, tachybrady syndrome, chronotropic incompetency, which is less common than the top three, and sinus exit blocks. The common causes of sinus node or manifestation of sinus node dysfunction is sinus bradycardia with pauses with tachybrady syndrome. الchronotropic incompetency or sinus exit is this common. We'll go over a few EKG example quickly. هذه normal phenomena, usually sinus arrhythmia. The P wave axis is normal, morphology بتاع P wave normal, but the PP is irregular. This is totally normal phenomena. Rarely it's pathological, and no indication to do any medical intervention in this situation. This is a telestrip example for sinus pause. You see a P wave, QRS, P wave, QRS, and then you're supposed to have يعني المفروض يكون في P wave هنا ما فيش P wave، المفروض يكون في another P wave هنا ما فيش P wave, and then you have a escape a beat, likely junctional beat. فهذه اللي نسموه فيها sinus arrest ولا sinus pause. Sinus exit block is يعني form of sinus pause, بس المشكلة إن sinus beat form inside the sinus node, but it does not exit. That's why we call it exit block. The only way to differentiate the sinus exit block from sinus pause is the PP interval. فلما جيت تشوف ال PP interval متاع الباز تلقاها عادة المالتيبل متاع PP interval normally. For example, هذا الexample اللي قدامنا. The PP interval during the pause, it's double the PP interval normally. And this is the definition of sinus exit block if you want to define it by 12 EKG. And this is the only, there's different kind of sinus exit block. This is the one that we can see on 12 lead EKG. The other form of sinus exit block, you need to do an EP study. Another example of sinus pause, you can see on a sinus beat, a QRS, and then you have a pause for 4.2 seconds. Usually patients, if they are awake, not sleep, they're symptomatic with pauses that's longer than 5 seconds. Patient يكون عنده دوخة, يكون عنده إغماء, أشياء من هذا القبيل. Another example of pauses that happen with AFib, usually conversion pause, and this is an example of conversion. You can see patient in atrial fibrillation وبعدين في pause وبعدين a sinus node comes back. So we call this conversion pause. Conversion pauses is normal, usually less than 5 seconds. If it's more than 5 seconds, it indicates that there's sinus node dysfunction. Tachybrady syndrome is one of the commonest diseases of sinus node dysfunction. Usually patients end in atrial fibrillation. Sometimes they have atrial flutter. The problem with these patients انك انت you cannot achieve sinus rhythm, يعني convert them sinus rhythm by ablation or anti-arrhythmic medication. You try just to do rate control by medication, you go fast and then suddenly they go slow. So they are symptomatic with both fast and slow. So they have tachybrady syndrome. So these are the family sinus node dysfunction. الشيء المهم انك انت تحدد اذا كان الكوزز اوف sinus node dysfunction reversible or not reversible، لان اذا كان هم reversible مش محتاج تزرع منظم قلب. الكوز بتاع reversible sinus node dysfunction electrolyte imbalance, specifically hyperkalemia, hypothyroidism, hypoxia, hypercarbia. Medication important cause of sinus node dysfunction. على رأسهم البيتا بلوكر والكالسيوم شانل بلوكر, anti-arrhythmic medication, digoxin, lithium, cholinesterase inhibitors زي البيريدوستجمين. And then common medication that can cause sinus bradycardia and also sinus pauses. بعد الcondition that causes autonomic dysfunction زي diabetes mellitus, الحالات اللي يكون عندك increased intracranial pressure can cause sinus node dysfunction. Vagotonia, increased vagal tone in athletes and young patients can سبب sinus pauses, usually for sleep, and usually they are not symptomatic. Infection that can cause sinus node dysfunction, typhoid, brucellosis, and sepsis. Cardiac surgeries can cause sometimes reversible sinus node dysfunction. امتى تحط منظم ضربات قلب او pacemaker في حاله الساينس نود dysfunction؟ محتاج للحاجتين، محتاج انك تتاكد من the patient is symptomatic، لان في a lot of patients they will have sinus bradycardia, their heart rate is less than 60, they're totally asymptomatic, pauses and they are totally asymptomatic. Those patients أنت مش محتاج تحط منظم قلب. If they have symptoms, والحالة الثانية إنك تتأكد إن السبب متاع ال sinus node dysfunction is not reversible. يعني if it's reversible مش محتاج تحط pacemaker. So and you have to have يعني documented symptoms related to the bradycardia. Chronotropic incompetency, it's a rare form of sinus node dysfunction. هذا my group of patients يبقى عندهم مشكلة في زيادة الهارت ريت لما they exercise or they are going through exertion or they're doing activities. عادة they're old but they can be young patients. Young patients يقول لك أنا كنت نجري على التريدميل وندير في exercise لحتى الهارت ريت متاعي ثابت على 70-80. تأكد الدايجنوستس هذه بأنك تحط على التريدميل وتحسب الهارت ريت بتاعه مع الاكسرسايز إذا كان does not reach 75% of age predicted. That's an indication for chronotropic incompetency. Symptomatic sinus bradycardia secondary to medication, that's essential. This is one of the commonest indication to put a pacemaker. مثال على هذا المرضى اللي عندهم دعامات ولا المرضى اللي عندهم cardiomyopathy, they need to be on a beta blocker, for example. والبيتا blocker is an important medication. تعرفوا it has mortality benefits in patients with coronary artery disease and cardiomyopathy. So it's essential treatment. وإذا كان the patient bradycardic, especially if they are symptomatic وتعطيهم beta blocker on top of it, then it's a problem. In this situation, يعني زراعة pacemaker is indicated. It's actually class 1 indicated. الحالات اللي contraindicated to put in a pacemaker في ال ACC وال HRS, we call it class 3, meaning it's contraindicated. الحالات patients اللي يبقى عندهم أي manifestation sinus node dysfunction, either pauses, bradycardia, chronotropic incompetency, and they are not symptomatic. يعني مش تزرع البيسميكر وتعرضهم للخطورة ما لهاش داعي. يعني إذا كان ما تقدر بثقة أنك تقول أن البراديكارديا هذه مسببة symptoms, you should not put a pacemaker. إذا كان البراديكارديا because of medication that's not essential, you should not put a pacemaker. في العادة في الساينس نود dysfunction لما يكون الهارت ريت متاعك أقل من 40 pauses أكثر من 5 seconds, هذه يعني usually patient symptomatic and usually you need to think about pacemaker seriously. Now we're done with sinus node dysfunction. We'll move down into the conduction system. So into تشوفوا في السكرين هنا, this is cross section through the heart. You're looking from the left ventricle to the septum. You can see an AV node with His. You can see how the His is very close to the aortic valve. It crosses the fibrous body to the left ventricle. A problem with the AV block is a problem of conduction. It's not generating for impulse, of course. And the indication to put a pacemaker in those patients, if it's irreversible, if the patient have symptoms, and they have signs of high-grade AV block, and we'll talk about that a little bit after this. So, شنو common reversible causes of AV block? Again, electrolyte imbalance, especially potassium sinus bradycardia, and even AV block in those patients. تشوفها واجد في patients with end kidney disease and على dialysis. If they miss dialysis, they will present with complete heart block and severe bradycardia. Medications, that's not necessarily can cause AV block. That's not an indication to put a pacemaker. Stop the medication. Infection, it's very important here. Endocarditis can cause transient AV block, but not necessarily is transient. And sometimes you can have persistent damage to the His and have persistent AV block. في سبب common هنا في أمريكا اللي هو Lyme disease. ما نشوفوش فيه في ليبيا. It's a transient AV block. It causes transit AV block. الممس نشوفه فيه في ليبيا can cause AV block. Cardiac surgeries, valve surgeries, especially aortic valve with TAVR, aortic valve replacement, can cause transient AV block. But إذا كان patient عنده baseline conduction abnormalities, you need to monitor those closely, and usually those patients will end up with a pacemaker. We'll talk about acute MI and AV block. There's a certain situation where the pacemaker needs to be implanted. Infiltrative diseases can cause AV block, like sarcoidosis. Sarcoidosis can affect the lung and also the myocardium. It's a common cause of VT. Sarcoidosis tend to like the septum, and because it likes the septum, it ends up damaging the His-Purkinje system, and it can lead to AV block. There's conflicting data, they can be reversible, not reversible. Some of the guidelines recommend you try treatment of sarcoidosis with immunosuppressants and immunomodulator and see if the AV block reverse, then you can avoid pacemaker. But most of these patients will end up either with defibrillator because they have VT or a pacemaker. Autoimmune diseases that can cause reversible AV block, زي systemic lupus erythematosus with ankylosing spondylitis. في congenital diseases that are associated with AV block, usually you see those kids. A common gene mutation اللي هو SCN5A. نحن في EP we deal with this gene because of rhythm issues. SCN5A هذا gene codes certain protein in the sodium channels. Loss of function of this can lead to Brugada, اللي هي congenital condition can lead to VT. نفس الجين هذا اللي ينظم في الصوديوم channel كان يسبب مشاكل في ال AV node and can lead to AV block. The same gene also can cause mutation of that gene can cause long QT type 3. Dilated cardiomyopathy, Lamin cardiomyopathy, هذا النوع جديد مش جديد له فترة ممكن أكثر من 7-8 سنين described Lamin cardiomyopathy. في ال EP we deal with this because Lamin cardiomyopathy present with AV block. تلقاهم عادة teens above 10 years old, they present with the congenital AV block. ومع الوقت هذول patient develop cardiomyopathy and advanced heart failure. في other genes that are associated with AV block like TRPM4 and so forth. I'm sure, and I'm going to go over the first level of AV block. I'm sure you guys familiar with this. The first degree AV block is a sinus arrhythmia. This is normal phenomena where it's not normal. I should not say normal, but it's not indication for pacemaker. The PR interval تكون أكثر من 200 millisecond. This is by itself is not indication for a pacemaker. الحاجة الثانية اللي هي ال AV وانكباك. أنت لاحظ ال EKG هنا ال progressive prolongation of the PR. Eventually you drop a P and then the next P conduct with a shorter PR. This is what we call Mobitz type 1 or a winkiback. This is a normal phenomena. You can find it in young patients. If you put Holter, when they go to sleep, they can have AV winkiback. This is not an indication for a pacemaker. So first degree and AV winkiback is not an indication for a pacemaker. Mobitz type 2, this is an indication that there's an infranodal disease, meaning في الدistal part من AV node والهس في abnormalities. And Mobitz type 2 PR في الحالة هذه يكون consistent ثابت, suddenly you have a P wave that doesn't conduct. So without progressive prolongation زي الحالة هذه. فهذا نسميه في Mobitz type 2, and this is one of the high grade AV block. الحالة هذه 2-to-1 AV block. You have P wave that every other P wave conducting, and you can have different degree. Every third beat can conduct. Third degree AV block, there is complete dissociation between A and B. As this example, I have other EKGs. We'll go over them quickly so we can reach pacemaker troubleshooting. So you can see the PR progressive prolongation, and then eventually you have a P that doesn't conduct down to the QRS, and you have missed QRS. This is AV winkiback. This is not an indication for a pacemaker. This could be an indication for a pacemaker. You have a consistent PR, this exactly same PR, and then suddenly you have a P wave that doesn't conduct down to the QRS. This is another example of Mobitz type 2 AV block. You have a consistent PR interval, and then suddenly you have a P wave that doesn't produce any QRS. And then again, it comes back, consistent PR, P wave doesn't conduct. Notice that the QRS is wide, so the patient in the bundle branch, and this is just a telestrip, you cannot tell which kind of bundle branch. So there's conduction disease at different level. This is an example of complete heart block. يعني usually patient هذا ما present to you في ER ولا في emergency ولا في ICU. They usually are very symptomatic and hemodynamically unstable. There's complete dissociation between A and V. يعني the PP interval is marching through. The RR, which is escape rhythm, usually it's less than 40 beats per minute, but it can be more than 40 beats per minute. The escape can be narrow if the escape coming from the junction, يعني جاية من below the AV node, ولا it can be wide, which is less reliable escape rhythm, and that's mean the escape coming from the ventricle, يعني distal. Wide and less than 40 is always unreliable rhythm. يعني لما تشوف complete heart block with wide complex tachycardia and the heart rate is less than 40, be ready, like you're gonna have a flat line, so you need to act quickly. This is another example of complete heart block, and the key, sometimes you can have a tricky AV winky block that if you don't have enough strip of it, it can look like complete heart block. The way you tell is انك انت you measure the RR interval and the PP interval. في ال AV winky block, the RR interval and the PP interval, if you march it carefully, and you can see progressive prolongation. But في complete heart block تلقى consistent interval. RR will or QRSs will PP interval are very consistent. معلش انواع الاسئله هخلوها عند اخر المحاضره عشان نحاولوا نكملوا المحاضره كامله ونستفيدوا منها. electrophysiology study rarely يعني نحن نحتاج ندير electrophysiology study عشان الاي بلوك، بس يعني تسهل عليك فهم يعني where's the level of AV block. هذين catheters inside the heart. There's a catheter inside the higher right atrium, catheter coming from a jugular vein going through the coronary sinus, another catheter in the RV. But most important catheter in this situation is the HIS catheter. فلما نستخدم I'm using this from a resource from a paper. This EGMs, this is not actually my patient, but the EGMs, and clearly you can see an A, H, and V. H his EGMs. The time between H and V هذا very important إنك تعرف شنو هذا التايم. إذا كان هو يعني normally should be less than 50 millisecond أو في حدود ال 50 millisecond. إذا كانوا أكثر من 100 millisecond معناه عندك disease. كان زي في الحالة هذه اللي هنوريها لك عندك A وعندك H وما فيش V معناها في block distal to the H, and this is a sign of high grade AV block. This is infranodal block. These patients end up needing a pacemaker or they need a pacemaker. عكس الموبتس type 1 تلقى عنده progressive prolongation في ال AH وبعدين eventually تلقى A وما فيش H لأن this is AV winky block. This is normal phenomenon. السلايد هذه important يعني إذا كان واحدة من السلايدز اللي بالذات الجونيور كارديولوجيست يعني تطلع من المحاضرة هذه بالسلايد هذه ف it's very important. يعني شنو الكلينيكال كلوز اللي يقولون لك من غير ما تدير اي بي ستادي؟ يقولون لك ان this is high grade AV block. يعني this patient محتاج منظم قلب. السؤال اللي تسأل نفسك هل البلاك تحت ال AV node يعني infranodal and Hesperkingi system disease ولا supranodal? Why that's important? إذا كان supranodal usually it's a benign phenomenon يعني it causes symptoms but usually it's not life threatening. إذا كان في الHIS and below or if distal part of the AV node it can cause serious AV block and can be life threatening. زي ما قلنا الموبس type 2 is more indicative of Hesperkingi disease infranodal disease. إذا كان على البيز لاين متاعك قبل ما يكون patient عنده AV block ولا أثناء patient عنده AV block عندك wide complex يا إما bundle branch ولا intraventricular conduction delay, that's another sign that this is a severely diseased conduction system. إذا كان زي ما قلنا الاسcape rhythm متاعك less than 40 and it's wide, it tells you that escape is coming from the ventricle, it's not reliable. You can have flat line quickly. The PR interval is not important. يعني the PR interval is indicative of the time of mainly in the proximal part of the AV node, not the distal part of the AV node. and also the time conduction between the sinus node to the AV node. فيعني not زي الexample اللي وريناه earlier, Mobit's type 2 كان ال PR normal, يعني totally normal. You can do carotid massage, يعني rarely we need to do this. بس لما تدير carotid massage, say the baseline heart rate بتاع البيشنت 80 beats per minute and you're having AV block, you're not sure it's AV block winky block ولا second degree ولا complete heart block. You can do carotid massage. It lowered the heart rate. If the AV block improve, that tells you it's a infranodal block, يعني hypertension disease. Why? لأن his system disease يقول لك أنا ما نقدرش نتحمل 8 beats جاية من sinus node. بس تو أنت lower rate by carotid massage to 60 beats. Now I can conduct 1-to-1. بس إذا كان he got worse معناها this is supranodal block. Another test in a simple test إذا كان البيشنت مش في الاي سي يو يعني وعلى فلور في القسم يعني ولا عندك في العياده you're not sure, you can walk them around وحط عليهم تيلي ستريب. إذا كان AV block it worse, that's a sign of significant disease. If it gets better, that's mean it's nodal disease. الاتروبين usually worsen high grade AV block. يعني لو عندك complete heart block وتعطي patient atropine, it can worsen the block, you know. شنو الانdication انك put pacemaker in patients with AV block? It's a little bit more simpler than sinus node dysfunction. Sinus node dysfunction is a little bit complicated. You need to make sure the patient is symptomatic. You need to make sure it's not reversible. But if you can عندك symptomatic second or third degree, you're done. You have to put منظم قلب يعني. إذا كان patient asymptomatic وعنده third degree وعنده unreliable escape rhythm, regardless of their symptoms, they need to have a pacemaker. حتى second degree Mobit's type 2. إذا كان عندك patient symptomatic with pauses more than 3 seconds and heart rate less than 40, and again unreliable rhythm, you think it's infranodal second degree block or 2-to-1 AV block, pacemaker is indicated. Patients with atrial fibrillation وعندهم pauses more than 5 seconds, especially if they are symptomatic, pacemaker is indicated. في حالات نادرة نحن نحتاج نديروا فيها ablation للAV node. لما يكون عندك patient عند atrial fibrillation عملنا له AFib ablation إذا كان candidate, عملنا له shock أو anti-arrhythmic medication و still symptomatic with AFib. last resort يعني الحل الأخير إذا كان you cannot convert them to sinus rhythm, تحط pacemaker. وعادة نحطوا a special kind of pacemaker, we call it bi-V pacemaker, اللي هو فيها 2 leads, lead في ال right ventricle و lead في ال left ventricle و ablated AV node. So the patient will be totally dependent on the pacemaker. Of course, this is a class 1 indication to put in a pacemaker. إذا كان patient especially valve disease, يعني aortic valve replacement, surgical aortic valve replacement or catheter-based TAVR, or patient develop complete heart block, and you think the patient is not, this is not reversible, it's an indication to put in a pacemaker. Certain diseases with AV block, even يعني low grade AV block زي الميتونيك dystrophy, هذول patients يبقى عندهم dystrophy of the proximal muscles. You need to put a pacemaker on those patients. Asymptomatic third degree AV block لما يكون عندهم heart failure because of the complete heart block, you have to put a pacemaker on those. في rare condition اللي هي exercise induced AV block second degree or third degree. And those patients يعني you have to put in a pacemaker. إذا كان الكوز متاع ال AV block مش ischemia during exercise. هذه another important slide. يعني another important slide that بالذات junior cardiologist. لما يكون عندك acute MI, patient جايك acute MI. إذا كان in the setting of the acute MI عنده high grade AV block. إذا كان this MI anterior MI, anteroseptal MI, then the conduction disease is severely present. يعني unlikely it will be reversible. Those patients likely, of course, you're going to stabilize them. If a stent or a thrombolytic, whatever is available, or a surgery for their coronary artery disease, you stabilize them with temporary at that point. But before they leave the hospital, likely they will need a pacemaker. لأن الهس system distally is supplied mainly by the left circulation, the LAD and left main LAD and left circ. The sinus node supplied by a sinus node branch from the RCA. The proximal AV node is supplied by a branch جاي من PDA. The proximal HIS is mixed supply between the branch from septal perforator جاي من LAD وبرانش جاي from the PDA. فالproximal يعني proximal part of the HIS عنده mixed supply من ال RCA LAD, but the distal عنده mainly supply from the septal perforator. فإذا كانك عندك occlusion في ال LAD و damage to the HIS that's permanent and a complete heart block, معناها the patient likely will end up a pacemaker. So if you have persistent second degree or third degree or infranodal block, you need to put a pacemaker. إذا كان عندك transit AV block second or third degree وعندك persistent bundle branch block. Remember, I always wide QRS is not a good sign لما يبقى عندك AV block. معناها عندك disease في conduction system at multiple levels. تمام؟ فيبقى عندك لما يبقى عندك persistent bundle branch block و transit bundle AV block, you should put a pacemaker on those patients. Alternating bundle branch معناها patient presented with acute MI وبعدين تشوف دي ال EKG اليوم عنده left bundle, next day you have a left bundle, right bundle, alternating between left and right. If you have alternating bundle branch block and you have AV block, that's a sign of significant AV nodal disease in a setting of acute MI. Those patients need a pacemaker. Pacemaker, في عندك temporary pacemakers وفي عندك permanent pacemakers. Temporary pacemakers عندك a transcontinuous pacemaker or transvenous pacemaker. A transcontinuous is very temporary, يعني it's very inconvenient to patient لما يكون patient واعي, يعني زي الشوك, small electrical shocks in the chest, يعني تحتاج إذا كان patient blood pressure stable تحتاج تعطيهم sedation. فهذه حل مؤقت جدا لعند لما تحط يا اما transvenous pacemaker يا اما تحط permanent pacemaker. عادة البادز تحطن ودائما في تفكيرك لما تحطن في العادة البادز مرسوم عليهن وين تحطن, بس في بالك دائما تخيل القلب لازم يكون sandwich between these two pads, يعني قاعد في النص بيناتهم. في عندك two options, يا اما anterior lateral ولا anterior posterior. وعندك البيسر when you put the on مثلا في الاي انت بتدير حل سريع هتحط وبعدين ينكريس الملي امبس الاوتبوت بتاعك الماكسيموم وتوطيه عندما تلوز كابشر وبعدين تحط سيفتي زون, وهذه الناب هذه دي adjust the rate. Different companies has different يعني system. لما تيجي في المستشفى تاكد من وين اماكن البيس ميكر والاوتبوت والشوك and so forth. الترانسفينوس بيس ميكر عباره عن جزئين, الكاثيتر نفسه والجنريتور. الكاثيتر we'll show you a picture of the catheter, بس هو عباره يعني يشبه الاسوان, في بالون at the tip. The tip has a cathode and anode. I will show you that later. But the generator very simple, يعني two kinds of boxes. يا اما عندك box single chamber يا اما عندك box that you can do dual chamber. في عادة 3 main knobs that you can adjust بتاع الانرجي الاوتبوت والsensitivity والrate. بعد ما تحط الكاثتر بتاعك تتاكد انك you capture, you minimize الكابشر لان لما lose capture وبعدين تزيد safety وبعدين adjust the rate depending on what rate you want to do وبعدين secure it and lock it. بالنسبة للtransvenous catheter عنده بالون, هذا safety feature عشان you flow through the tricuspid valve وأيضا to prevent perforation as you advance to the RV. الكاثيتر لما تعمل عليه زوم عنده تيب وعنده رينج. البيسنج يحدث between الكاثود والانود في التيب. وبعدين عندك الكونكتورز اللي هو الكونكت عن طريق وايرز للجنريتورز. هذه السرنج اللي اوكي. حاجه اجين للجونيور كارديولوجيست تعود عينك عليها لما تحط بيس ميكر, always look at the EKG. When you pace in the RV you should have a left bundle morphology in V1. هذه tells you أول حاجة إنك you're capturing الحاجة الثانية it tells you you are in the right chamber. يعني every now and then you might have an arterial access. It's rare complication, but it can happen. Arterial access, the transvenous catheter goes through the septum into the LV and passes in the LV. وفي الحالة هذه زي ما حنوريكم بعدين يكون عندك right bundle morphology in V1. الخلاصة لما تدير transvenous pacing لازم يكون عندك left bundle في ال V1 ويكون عندك negative QRS في الانفيريور leads. تمام؟ البيسميكر permanent pacemakers. البيرمننت pacemakers يعني تطورا من 1958 إلى اليوم هذا تطور كبير. The first pacemaker was external, was a huge machine, ما فيش something implantable until 1960. بعدين التطور الأهم اللي صار في البيسميكر اللي هو الفيتشرز البروجرامينج مع تطور الكمبيوتر تشيبس والسمارت والارتفيشال انتليجنس. البيسميكر اصبح عندهم القدره فور اكزامبل ريت ريسبونسفنس، يعني عندهم القدره انه يتاقلم مع الاكتيفيتيز بتاع البيشنت ويزيدن الريت ويخفضن الريت واذر فيتشرز. في 2011 الفيرست تايم اصبح عندنا بيس ميكرز ذاتس ام ار اي كومباتبل. ان ذا باست يعني لما تحط بيس ميكر البيشنت كان كونتر انديكيتد تحطها في الام ار اي ماشين لعده اسباب. الام ار اي نمبر 1 تسبب الكترومagnetic انترفيرنس في البيس ميكر زي ما حنوريكم بعدين، فممكن تلخبط البيس ميكر. It can also interfere with the algorithm of pacemaker processing. It can flip the pacemaker pacing modes into different modes. وبعدين there was a concern that with MRI you heat up the lead، يعني تسخن الليد وممكن تسبب damage to the lead. بس في 2011 بدأوا يصنعوا في pacemaker that MRI compatible. Today يعني 99% of the time most of the pacemaker that's in the market يعني implanted is MRI compatible. يعني تقدر تدير أي MRI البيشنت عنده بيس ميكر تأكد بس إن هي MRI conditional أو MRI compatible. المشكلة بس في الMRI بتاع القلب يعني أحيانا يكون عندك artifact ما تشوفش القلب بوضوح لما يكون عندك بيس ميكر with the lead inside the heart يصير في artifact من الليد، بس في برضو في طرق معينة إنك أنت تخفض الارتيفاكت هذه. وأخيرا الليدلس بيس ميكر هذه نحطوا فيهن عن طريق كاثيتر ما فيهاش ليد اتول، يعني وتخش بسبيشال كاثيتر into the RV و deploy the pacemaker زي I'm going to show you an example. الليد pacemaker عندنا 3 kinds of lead pacemakers. عندك اما single lead pacemaker فيها ليد واحد يخش عن طريق tricuspid valve to the RV، اما في ال RV apex ولا RV OT. في اليونايتد ستيت يعني هنا في امريكا نحن بالعاده single lead ونحطه في ال RV lead، rarely يعني نحطه atrial lead. في Europe I think they still put a single lead in the atrium without any RV. السبب ان a lot of patients with sinus node dysfunction تحط لهم atrial lead بس مع الوقت حيديفلوب AV block good portion of them and you end up putting another lead. فيقول لك يعني من الأول حط bi-V أو dual chamber pacemaker on those patients. ففي single lead pacemaker وفي dual وهذه الموست common device اللي نحن نزرعه فيهن لأن dual chamber pacemaker فيها lead في الاتريوم وفيها lead في ال RV. Usually we implant those in the left subclavian. Unless you have an access problem, you can implant it in the right. في some يعني operators they prefer right implantation on the right, or if you have a vascular problem, you implant it on the right. Or if the patient is left-handed, sometimes it's not convenient. يعني إن تقول له ما تحركش يدك لمدة 4 شهور هو يستخدم في يده اليسار تصبح عنده مشكلة. وهذا كلوز اب لأحد أنواع البيس ميكر. النوع الثالث من البيس ميكر اللي هم نسموا فيه من باي في بيس ميكر اللي هو يكون عنده عادة ار في ليد واتريال ليد وفي ليد يمشي من الكورونري ساينس into the LV and pace epicardially through the coronary sinus to the LV. فيصبح عندك synchronization between the RV and the LV and تقدر promote synchronization. Commonly we implant those in patients with patients, for example, اللي عندهم a lot of RV pacing وتسبب cardiomyopathy زي ما هنشوفه في نهاية البرزنتيشن. patients عندهم cardiomyopathy والEF بتاعهم مش low enough تحط CRTD تحط لهم LV lead to improve LV function. The X-ray, how it looks like if you're having normal position leads. لازم لما implant pacemaker تدير X-ray immediately after implantation. عادة هذه portable تجد AP بس تأكد إنه ما فيش pneumothorax والposition تاع leads okay. بس before discharge عادة إذا كانك you admit patient after pacemaker في بعض الناس يعني في داتا انك تقول تقدر تخرج البيشنت immediately after pacemaker. انا ندير في دخول البيشنت يقعد overnight و next day we do an X-ray AP و lateral. الimportant X-ray is lateral. انت لما تزرع pacemaker lead in the RV especially the RV should be pointing anterior toward the sternum. If you point posterior this is an indication that it's an LV placement. أحيانا يصير في complication in the procedure. You access the arterial subclavian, pass the wire into the LV, and هذه complication that should be avoided. لأن lead if it stays in the LV, it's a risk for stroke. A leadless pacemaker, it's a new pacemaker. Basically نخش عن طريق الفيمورال vein with a special delivery catheter زي ما في picture. هذا الكاثيتر enable us to يعني negotiated tricuspid valve. You فيها manifold الكاثيتر at the back. You inject contrast once you reach the RV. تحط we call it the cup against the wall. You should be against the septum. يا اما في RV او T septum ولا down closer to the apex و to inject dye to make sure الكب مغطي على السبتم وما فيش leak وتأكد من البوزيشن بتاع الليد. and then you deploy the pacemaker في special tool in the back يطلع عن التاينز هذين اللي هن كيف العلاقات يمسكن في الترابيكولي بتاع الRV وبعدين تسحب الكاثيتر and you test the pacemaker. This is a totally leadless pacemaker. ما عندكش wire. This is an option if you need to put a single chamber pacemaker. يعني زي مثلا old sick patients ما تبيش تحط wires و risk of infections. You don't have a vascular access. هم عندهم AFib. أنت محتاج بس a single lead in the ventricle to pace as a backup or pace all the time. The option يعني any indication for a single chamber pacemaker is indication for a leadless pacemaker. الباتري يعني they claim and the battery can last up to 9-10 years I think. بعد ما you pull it there's a wire in the back, you cut it and you just leave the lead in. هذه how it looks like if you in the X-ray you should do both AP and lateral. I don't have an X-ray for lateral for this patient. The pacemaker بالنسبة lead pacemaker has basically two components. The lead والcan نقول لها can اللي هي pacemaker itself. الcan فيها الباتري والcomputer chip بتاع analyzing algorithm. والlead اللي هو الواير that deliver energy to cause myocardial contractions, and it's also like the antenna that's sensing what's happening in the ventricle. And there's two kinds of leads. There's the active lead. It has a helix that you deploy from the back. هذا يخش في الميوكارديوم ويمسك في الميوكارديوم وتمنع dislodgement. ولا في الباسيف lead. الباسيف lead just has tines يعني كيف الشوكات انت تحطها من غير you deploy anything والlead مع الوقت يدير scarring و heals into the ventricle. لما تدير zoom by X-ray on the can itself, lead عنده two parts hooked in the back, tip conductor connector to the conductor والring. بالنسبة leadless pacemaker الكاثود والانود عبارة اللي هو الرينج اللي هو الانود in the back, الكاثود اللي هو التip in front of these tines.
دكتور محمد.
نعم.
معلش سامحني يلا انتربت يو. اعتقد ان احنا ممكن نوقفوا. يعني انت مشكور غطيت الانديكيشنز، يعني التايبس اوف بريديكارديا، ساينس نود والاي في بلوك، وتو احنا خاشين الجزء الثاني يعتبر اللي هو البيزكس اوف بيسنج وبعدين ترابل شوتنج. فلو ما عندكش مانع نقدر نخلوها مثلا محاضره جزء ثاني. احنا عندنا مجموعه اسئله، عندنا حوالي 6 اسئله. فنقدر we can address the questions، لان تو نخشوا في يعني زي ما قلنا البيزكس اوف بيسنج وترابل شوتنج. هذه تقدر تكون محاضره ثانيه لانها حتكون at least we need another 30 or 40 minutes يعني. فلان احنا الوقت مربوطين بالوقت، فنقدروا ان address the questions لو ما عندكش مانع.
تفضل.
خلاص. فطبعا احنا الاكسبرت بانل عندنا الدكتور ناصر والدكتور خالد بوزقية. فعندنا مجموعة أسئلة زي ما قلنا، فحنقدموا لهم الأسئلة هذه. فكان تعطوني لحظة بس. الله يملك دكتور خالد as a co-host. لو في أي أسئلة طبعا اكتبوها في الشات بوكس وحنجاوبوها إن شاء الله. لو في حد يعني يبي، لو في حد يبي يتكلم يقدر يعني raise your hand.
السلام عليكم ورحمة الله. شكرا دكتور محمد.
was
a nice presentation. My name is دكتور ناصر مسماري. بس حاب نجاوب على سؤال دكتور رجب.
يبدأ انت دكتور how to define chronotropic incompetence دكتور ناصر.
دكتور رجب طبعا سأل على definition of chronotropic incompetence. طبعا زي ما ذكر دكتور محمد لبيدي، دكتور محمد ذكر ان الكرونوتروبيك انكومبتنس جزء من الساينس نود ديسفانكشن. هي طبعا اقل في الفريكونسي بتاع الساينس اكزيت بلوك والبراديكارديا والتاكيبرادي سيندرومز. طبعا هي ديفاين ان هي inability to increase the heart rate adequately during exercise to match cardiac output والfunctional capacity. طبعا الكرونوتروبيك انكومبتنس can be diagnosed زي ما قال دكتور محمد by exercise ECG، وسيمبلي ممكن حتى بالهولتر، يعني ممكن يجي حتى هولتر during الووكينج او during stress ما فيش increase في الهارت ريت response للاكسرسايز. طبعا هي highly prevalent مع البيشنت with heart failure patient. طبعا كل البيشنت with heart failure عندهم اصلا هم يعني low cardiac output ولو functional capacity. بالنسبه للبيسنج بس هم اضافه واحده للكرونوتروبيك كومبتنس، عاده يستفيدوا اكثر من الريت ادابتيف بيسنج اللي هو المود الاخير في البيس ميكر اللي هو الار الاخيره، يستفيدوا منها اكثر من غيرهم. يعني هذا الديفينيشن اوف كرونوتروبيك كومبتنس. ممكن دكتور خالد تجاوب بقيه الاسئله؟ تفضل خالد.
لحظه دكتور ناصر، السؤال الكرونوتروبيك انكومبتنس هل عنده رقم معين؟ يعني what is the percent of maximum age predicted heart rate؟ لو مش عارف انت ذكرتها ولا لا.
هو الماكسيمم هارت ريت ديبند على البيشنت دكتور، ديبندز على كل مريض خاص به. يعني الماكسيمم هارت ريت اللي التارجت هارت ريت اللي ديورنج الاكسرسايز على كل مريض حسب الويت والهايت والفانكشنال كاباسيتي بتاع المريض الروحي. يعني
هو في طبعا
حسب التارجت هارت ريت بتاعه هو لازم يشوف التارجت هارت ريت بتاعه.
طبعا 85% maximum age predicted heart rate هذا عاده تارجت في الستريس تيست. فالكرونوتروبيك incompetence can be accepted like حتى 80%. يعني if you can achieve 80% 80 to 85% that's acceptable. اي حاجه اوطى من هيك يعني you're below the target يعني. فit's suspicious for sinus node dysfunction. السؤال الجاي خلينا نعطيه لدكتور محمد لبيدي اللي هو من دكتور اسامه بهليل، اللي هو السؤال neurocardiogenic modulation as a management of symptomatic sinus bradycardia. What's the role of neurocardiogenic modulation? What's the evidence? دكتور محمد لبيدي.
The evidence is very weak. يعني cardio inhibitory conditions like autonomic dysfunction that leads to cardio inhibitory reactions. يعني زي patients with multi-system failure secondary to advanced diabetes, a common example. لما يبقى عندهم syncope secondary to hypotension and bradycardia, the evidence of putting pacemakers on those patients is not very strong. لأنك you correct the cardiac inhibitory problem of heart rate, but not necessarily the hypotension. لأن the process is not only affecting chronotropy, it's affecting also the blood pressure. So there's issues with vascular resistance. فبعض المرضى يستفيدوا منهن، بعض المرضى ما يستفيدوش من البيس ميكر. نفس المشكلة هذه تلاحظها في الفيزو فيجل سينكوبي. يعني الفيزو فيجل سينكوبي the evidence of pacemaker is very weak. يعني the evidence of pacemaker benefit for vasovagal syncope found only if you document عندك pauses مع الفيزوفيجل في patients older than 40, and it's a very small group of patients. كذلك neuromediated autonomic dysfunction leading to bradycardia. اصلا هذه not very common disease يعني.
ماشي دكتور خالد بوزقية، عندك مشاركة باسم الموضوع هذا.
Yes, so this is a growing this is an area of interest within the AP community, especially in the last 12 months, I think. Interestingly, I did my first cardio ablation last Monday, which was the first in the UK. So there is a growing evidence of benefit, especially for a young patient, who I agree with Dr. Mohamed that putting a pacemaker in a young patient with vasovagal or profound sinus bradycardia is not something we are keen to do because of the potential complication of pacemaker. Also, as Dr. Mohamed said, they may not benefit from pacemaker. However, that there is now emerging role for cardio-neuroablation, which essentially just, obviously this is too advanced for this meeting, but essentially means just modifying and ablating the ganglion plexus, the parasympathetic one, to stop inhibition of the cardiac system. And the case I did on Monday was dramatic improvement. It was a young lady, 33, profound sinus bradycardia with no explanation and no cause. And she had a dramatic response. Her heart rate went up to 80 beats per minute and blood pressure improved and she felt dramatically better. So I think there is growing evidence. I agree that we are not quite there yet, but for this young population who we should avoid putting pacemaker in, and despite all lifestyle changes, that I think there is a role, and the evidence is becoming more stronger and stronger. But I think this is quite advanced and complicated procedure. And I think we need more evidence and more randomized trial.
شكرا محمد.
It's behind the scope of this talk. Khalid,
yes.
These patients, Dr. Bouzguiya, these patients with neuromodulation, ganglia ablation, my recollection, I don't do this, I have not done yet the ganglia ablation, but my collection from the data, and it's useful in patients with vagotonic AFib, young patients and them very profound sinus bradycardia, and usually they flip into AFib. Usually those patients, if you do just AFib ablation, they go back into it. So the ablation of the ganglia might benefit in those patients to improve the bradycardia and prevent the AFib. So the modulation ablation, regardless if you have AFib or not, you do it?
Yes, so the indication for this is anything vaguely mediated. So one of the, for example, for our case, for any case to consider them for this is you have to prove it's functionally and vaguely mediated. So for example, our patient, we given her 2 milligrams of atropine to ensure that her heart rate responds before you could consider them for this ablation. I think the same for intermittent heart block or vasovagal. So there is definitely evidence for vaguely mediated AF, I agree, but the evidence now growing for even sinus, symptomatic profound sinus bradycardia, and also functional intermittent heart block. You have to make sure it's functional. So if it's Hesperkinji disease, there is no point doing it.
اوكي هو طبعا للاودينس طبعا اتس بيوند سكوب يعني شويه هاير ليفل ممكن الكتروفيسيولوجي اكثر لكن الاودينس AFib ablation itself the PVI can also been shown in studies by Hassiger group or other studies in there's improvement in sinus node dysfunction after PVI or it could be related to the neuromodulation. I mean, if that's maybe the take-home message يعني bottom line. It's an interesting field وأكيد حيكون في studies أكتر وكويس. Okay, we'll move on to the next question. Dr. Jeb, asymptomatic pause in AFib. يعني someone who has AFib but had an asymptomatic pause longer than 5 seconds. How would you manage that, Dr. Mohamed? How would you manage someone like that, asymptomatic pause more than 5 seconds?
Yeah, if they are asymptomatic, I would be really reluctant to put a pacemaker. يعني the sinus node dysfunction, then the benefit of putting a pacemaker mainly to improve symptoms. So إذا كان أنت عندك sinus node dysfunction and patient is not symptomatic, putting a pacemaker won't change anything. So لو عندك patient with AFib, baseline heart rate in the 40s, and he's having a pause of 10 seconds, that's a different story. That's when you have a heart rate in the 40s, that's not very reliable rhythm, then the pacemaker will be beneficial. But the rule of thumb is asymptomatic, pause, especially if it's during sleep, I won't put a pacemaker on those patients.
Dr. Osama Bhilil, how to differentiate how to differentiate between non-conducted P waves and intermittent high-grade AV block. Dr. Khalid Bouzguiya, how to differentiate between non-conducted P waves and intermittent high-degree AV block.
Yeah, so this is really come down to measuring the PP interval. So non-conducted P wave is either prematurely early or late. So if you measure your PP interval and your P interval is very early, this suggests it's likely to be non-conducted P wave, or the same if it's very late. So this is why it's very common mistake when interpreting 24-hour Holter is non-conducted P wave can be mistaken for a degree of high-grade AV block. So the key message is, I think Dr. Mohamed is just trying to put the slide where maybe he showing, but the key thing is to measure the PP interval. Yeah. And this is very common mistake, and it's really important. Whenever you see a second degree or a complete heart block or anything on a Holter monitor, please measure the PP interval, because if it's especially MOPTIS type 2 or type 1 can be mistaken for a non-conductive P wave. Anything to add, Yusuf?
It's حتى it applies to isorhythmic dissociation. حتى isorhythmic dissociation, sometimes it's difficult to differentiate. It's not really complete heart block, but you have to measure and maybe print out a longer strip. Look at longer strips to figure out what the relation is. هذه مهمة جدا يعني.
Yusuf, I think you missed a question from Osama before this about
how long we wait in case of AV block post valve surgery and حتى post MI. How long do we wait? السؤال هذا. دكتور ناصر موجود معنا. دكتور ناصر شو رايك في موضوع لو عندك اي حاجه بتضيفها دكتور ناصر على البي ويف شاركنا بالنسبه للبي ويف والهاي ديجري اف بلوك, then we can go next to the انت طبعا you read the Holter monitors يعني دكتور ناصر. If you see rhythm strip and if there's dissociation, what do you do? يعني give us an advice للاتtendees يعني.
Yes, as Dr. Khalid Bouzguiya said, I will look for PB interval. PB interval, it's marched out or not. التايم والله في early P's ولا late P. فذات differentiate between الدروب beat and الهارت بلوك. بس في سؤال ثاني دكتور اللي هو طبعا مش هو سؤال, اللي هو ملحق للكلام يعني. Sometimes we have a rare phenomena which is called isorhythmic dissociation. Sometimes we have the atrial and ventricular rate with almost same rate. So it's hard to differentiate between that case on first degree heart block. I saw last week a patient with complete heart block and Holter with complete AV dissociation, and then he got isorhythmic dissociation. It's the same duration between P and R's. So how we can differentiate between in this case first degree with fixed PR interval and heart block? مش عارف سؤالي واضح ولا لا؟
لا، الإجابة واضحة، الإجابة واضحة. هنا ناقشنا الأيزوريثميك ديسوسيشن، وطبعا هي في الهورتر دائما الواحد يحاول يشوف اللونجر ستريبس، لأن في ستريبس افيلبل. يعني الهورتر حتى يعني انت تدير داونلود الهورتر بتاعك بروحك، ولا في تكس يساعدوا فيك دكتور ناصر؟ لأن مرات you can look at the actual rhythm strips يعني كلهم. لما تاخذ الفاينل ريبورت you just may lose الانترفال اللي انت بتشوفها. فكيف تدير فيها انت؟
دكتور يوسف، نحن يعني مش حنعتمد بس على الريبورت. يعني احنا عاده عندنا الريتم ستريب بشكل عام نطبع في مجموعه ريتم ستريبس، يعني لونج ستريبس سبيشالي 2. يعني هو عاده الجايد لنا خاصه في الحالات الادفانسد اي في بلوك والحالات اللي زي هذينا، عاده اللونج ستريب حتى يكون كافي، خاصه في وجود ال 12 ليدز فاسيلتي. يعني حتى في سم هولترز في 12 ليد وفي 6 ليد فاسيلتي، ممتاز ان بامكانك تغير الشانل زي ما انت تحب، تغير ليد 2 وتغير ليد شيست ليد لمليد زي ما تحب يعني. فبالتالي وفي نفس الوقت حتى الفولتج بروحه، يعني احيانا sometimes يكون البيز مش واضحات واجد في الستربس بتاعتك، فبالتالي انت تزيد الفولتج بتاعك عشان تبين
كويس
البي ويفز.
كويس. هذه ملاحظه مهمه. وطبعا يعني at the end of the day حتى الكلينيكلي والوقت what's the timing of الابيسود. يعني لو انت شفت هاي جريد في بلوك الساعه 3 الصبح versus الساعه 2 الظهر مع symptoms patient reported symptoms, that's a big difference يعني.
الحاجه الثانيه بالنسبه للاي بي بلوك، يعني نحكي على الانترست بتاعي يعني في الهولتر. انت اللي يكون الايم بتاعك انك تتابع الاي بي بلوك. يعني sometimes نشوف فيها بكثره، يعني انه يكون فاريبل بلوك، يعني ينتقل حتى من ستايب 1 موب ستايب 2 يدخل في كومبليت ويرجع، فيكون يعني مخادع. يعني في بعض الاحيان انك ما تنتبهش للادفانسد اي بي بلوك، بس يكون الظاهر قدامك عباره عن موب ستايب 1 ولا فيرست ديجري هارت بلوك. لكن في بعض التايمز خاصه during الايرلي مورنينج تايمز والسليب تايم، فبالتالي انك تركز الجريدز هذين يعني. ظاهرة الالجوريثميك ديسوسيشن طبعا هي نوت كومن. انا مش عارف، انا ممكن شفت حاله واحده انت ممكن في الهولتر، لكن طبعا تحتاج ان الواحد يحطها في باله يعني.
اوكي. الديوريشن اوف waiting after يعني عندك event which you think it's going to be reversible. المثال اللي هو post valve surgery, how long do we wait, and post MI, how long do we wait? خالد, go ahead please.
I don't have much experience. ممكن دكتور خالد
تمام نشوف دكتور خالد يعني مش سؤال دكتور خالد. شنو رايك دكتور خالد؟
Well, very good question now, Saman. Obviously, it depends. Usually, for example, let's say about post-aortic valve. Usually, if there is a degree of heart block with aortic valve, I'll have a very low threshold for considering pacemaker, because these are unlikely to recover. However, it is my practice. It depends on the patient scenarios. Most of our patients will have epicardial wire, and so we have time. And we don't have to rush into taking these patients to the lab, especially if you get complicated infection. Then the benefit, I think the risk outweigh the benefit. So my practice, generally, I take everything into considerations. I wait a minimum of a week, maximum of 2 weeks to decide on the pacemaker. But generally, I don't implant it before a week. But I will have low threshold for considering pacemaker. I don't know, Yusuf, what is your practice?
نشوفوا دكتور محمد البيدي. What do you think? Let me try you guys first.
I agree, especially aortic valve, because how close it is to the HIS. You don't know what the surgeon injury to the HIS looks like. It's tougher question في حالة التافر اللي هي transcatheter aortic valve. The data is still not very clear. بس I agree with Dr. Ganglia على not rushing into putting a pacemaker. بس لو يكون عندك patient, for example, عنده baseline right bundle branch block وعنده fascicular block وعنده first degree block, you know that the conduction system is hanging by a thread. And actually there's data in TAVR patients who has a baseline right bundle, they end up with TAVR, and they follow these patients. The patients that had most complete heart block are the patients with the right bundle. So I agree with Dr. Khalid. If you have aortic valve, I would be careful. I would really consider putting a pacemaker. I would wait at least for a week. For TAVR, the same, unless I have a right bundle, I won't wait that long. Maybe I would put it sooner. بالنسبة للacute MI, it's a very difficult question. For right RCA infarction, you can wait because likely this complete heart block will reverse. But you cannot keep the patient in the hospital after acute inferior MI for weeks and weeks. I had a situation, a patient came in with inferior STEMI, had a complete heart block. We put in a temporary pacemaker. He has a kidney transplant on immunosuppressant. And he had a temporary pacemaker for good 4 or 5 days. Every day we check in, he has a very unreliable escape rhythm with complete heart block. So by the end of the week, I put in a pacemaker, and 2 months after the pacemaker implantation, he had minimal RV pacing, like he didn't need the pacemaker at all. So you stuck with these situations, sometimes with inferior MI, that you cannot just, it's a risk of infection, the catheter sitting there for weeks. Now, if you have anterior MI, I won't be shy to rush into putting pacemaker. Once the patient stabilized, they fix the LAD, they have a complete heart block, and they see there is indication for a pacemaker. Those patients need, it's very unlikely the conduction disease will be transient, it will be permanent.
تمام شكرا محمد. طبعا يعني there's no well-defined time when to implant a pacemaker. طبعا الكونكلوجن انه زي ما قلتوا depending on clinical scenario. رقم واحد يعني inferior wall MI will wait longer versus an anterior wall. Anterior wall, we know there's more massive damage, most likely they won't recover. I personally post surgery I wait about 5 days, يعني a week. There's a patient who's in the ICU, who's going to be in the ICU for a week. It's going to be so long for them to stay in the ICU. There's more risk of infections, DVTs, PEs. Usually, I think by 5 days for me. And definitely not beyond 7 days. Like in 5 days, I think it's reasonable to wait. السؤال الثاني عندنا سؤال أخير دكتور جب على patient with complete heart block. So if you have a patient at your center and they come with complete heart block, you don't have a temporary pacemaker, no temporary wire. What's the role of dopamine infusion during transfer? Dr. Mohamed Labedi, can we use dopamine and what's the role? Is there any data or what do you think?
Yeah, ما عندكش any other options يعني transcutaneous or dopamine.
Yeah.
I'm not sure about the data of double complete heart block. بس إذا كان عندك مشكلة permanent في infrahistine conduction system, giving dopamine, dobutamine, isoprel might increase your escape rhythm, might improve the AV block and the His conduction, but it's a permanent problem. You need to fix it. So it's not reliable. بالذات لما يبقى عندك complete heart block وescape زي ما قلنا أقل من 40 beats per minute when it's wide, don't feel comfortable with just drips or transcutaneous pacing. You should not transcutaneously pace for a long time. You should put in a temporary until you address the permanent pacemaker.
تمام. Khalid, do you use isoprostanoid or dopamine? Do you have any preference?
So it's a very difficult situation, Yusuf. Usually, if I have to use something, I will use isoprostanoid infusion. Now, the problem is we know that if you have a distal or hyperkingy or progressively worse cardiac conduction disease, isoprostanoid will not help, and in fact, it may sometimes make the situation worse. The answer is always pacing, and the question is whether you will have the facility to do transcutaneous pacing with sedation and then transfer the patient for some form of transvenous pacing. I think isoprostanoid is an option, but be prepared that if this is a hyperkingy or distal conduction disease, isoprene may not help, and in fact, it may make things worse. So I think in my opinion, every cardiac center should be at least have the facility of temporary pacing wire.
Temporary pacemaker.
Oh, yeah.
I totally agree. I mean هذه زي الأكيوت MI بس للEP يعني you should have temporary pacemaker available.
دكتور محمد لبيدي، السؤال الأخير بناخذه اللي هو من الدكتورة هالة. If you can clarify, you mentioned in your talk the effect of pacing on V1. What should it look like? Left bundle, right bundle? If you can clarify it, please.
Excellent. Let me just go over the slide. I think I have a slide for. There you go. So if you pace in the RV, think about it the opposite. If you're pacing in the RV, you should have a lift bundle. لأنك الفيكتور متاعك V1 is sitting in the fourth intercostal space on the right side. So the vector of electricity is going away from the positive pole of the integrated lead V1. So if you have a vector of electricity going away from the positive pole, it will give you negative deflection. So in V1, you will have the spike and you'll have left bundle morphology. And in V6, because the vector is going toward the lateral side of the ventricle, you should have, and it's integrated lead, so it's going toward the positive pole, you should have positive deflection in V6. That's if you're pacing in the RV. If you have a situation, for example, if you have a bi-V pacemaker and you're not pacing in the RV, you're using mainly the LV to pace, you should have the opposite, because now you're pacing closer to the lateral wall. So the V6 should be negative, but you're going toward V1. So V1 will be positive. You will have a right bundle. It depends where the CS lead is sitting. Not a lot of time you will have a huge R wave in V1, but usually any positive deflection in V1 during pacing is suggestive that the pacing source is in the left ventricle. The bottom line, if you're pacing in the RV, you should have a left bundle in the V1.
تمام. يعني هي زي ما ذكرت محمد ان ال V1 is going to be anterior, يعني on the chest wall, closer to the right ventricle. right ventricle is anterior, فهيكون pacing from the right ventricle is going to be right bundle. It's going to be negative in V1. والعكس لأن ال LV pacing, LV is more posterior, so there's going to be some positive deflection in V1. تمام. خالد في أي إضافة؟
Yeah, Yusuf, this is a really important message. I think if we just make it simple for dual chamber pacemaker, you have a patient who have an RV lead, and as a physician, you see their pacing rhythm and you expect it to be left bundle morphology, right? As Dr. Mohamed clearly explained. So if you are seeing a patient with just dual chamber and you see that the ECG shows actually right bundle morphology, as in positive in V1, you need to be worried, is the lead in the correct position? There is exception. So sometimes it can still be in the right position if the heart is rotated, or if your actual lead is more septal and capturing some of the left bundle. So in that situation, if you see a patient with right bundle morphology as positive V1 in a patient with a pacemaker, you need to make sure that the lead is in correct position. That involves, as Dr. Mohamed nicely explained earlier, doing lateral chest X-ray and doing a quick target echo. Because if the lead is in the left ventricle, then the patient will be at risk of a stroke and need to be anticoagulated. So this is really important messages. If you see that, it's really important you do lateral X-ray, and if you're not sure, you do a quick echo to make sure the lead, you could see it in the RV, not in the LV. And sometimes you may even need to do a CT. And that's a really important message. So I thought I'll just re-emphasize.
Dr. Mohamed, أنا موضح, if you can explain, Mohamed, the location on the chest X-ray, please, that leads.
So the key is the lateral lead. The RV, like Dr. Yusuf pointed, the RV is the anterior structure. So if you're in the RV, the lead should be going toward the sternum, so it's going anterior. If you're in the LV, if you by mistake access the subclavian artery and you're all the way down to the LV, the lead will be pointing posterior. Sometimes, especially in old females with severe scoliosis, the heart position is abnormal. They can be rotated, but this is the exception of the rule. I think we should just be focused on this message is lateral X-ray, the lead, if it's in the RV, should be going to the sternum. If it's in the LV, it will be pointing posterior. So it will be pointing opposite, totally opposite direction.
So there's a criteria that I would like to add that if you have a right bundle and transition is in V3, that may still be septal, okay? If you don't see a transition in V3, then this is a problem, okay? Yani I wish that I have an example, like I had a case not too long ago. Well, I'm sure I did a right-sided implant, it's right ventricle, like, and I noted that the transition was in V3. فهذه something else to add. طبعا chest x-ray is الفاصلة يعني ديروا chest x-ray lateral, look at where the lead is. If it's anterior, it's good. If it's very posterior, then you're in the LV. في الدكتور ناصر احنا we need to conclude soon فناخذ الدكتور ناصر بعدين we will wrap this up. دكتور ناصر تفضل.
على السريع بس دكتور يوسف.
تفضل.
دكتور محمد خالد. بس يعني في الجنرال براكتس يعني في sometimes خاصه الجينيور دكتورز يعني فنشوف مثلا اي سي جي بتاع بيس ميكر without spikes انا يعتقد ان مال فانكشن يعني طبعا هي في ترابل شوتنج بس حذكرها يعني ثم يعني الجزئيه بتاع السنسنج مود وشوف الرثم بتاع المريض اصلا فيعتقد ان البيس ميكر بالفانكشن جاست تيك كير في البوينت هذه انك انت مرات تشوف البيسنج رثم ومرات تشوف سنسنج مود يعني.
احنا ان شاء الله باذن الله دكتور محمد لو موافق باذن الله نحاولوا نديروا جزء ثاني اللي كانت هي فعلا يعني اكسلنت برزنتيشن دكتور محمد بارك الله فيك. انت بيج تاسك انك انت تتكلم على many things very comprehensive في وقت قصير. فان شاء الله باذن الله نحاولوا نديروا النكست توك نتاع الاي بي سيريس تكون على البيزكس اوف بيسنج وترابل شوتنج باش يكون عندنا وقت اطول للاسئله. شكرا على مشاركتكم كلكم، والمحاضره هذه متسجله باذن الله نحطوها على اليوتيوب شانل نتاع جمعيه القلب الليبيه. يعني اللي ما قدرش يحضر محاضره كامله ويبي يعاودها ان شاء الله هتكون موجوده متوفره على جمعيه القلب الليبيه. وشكرا لكم جميعا وعلى مشاركتكم، وان شاء الله باذن الله نتواصل باذن الله على الموعد الجاي للاي بي سيريس مع جمعيه القلب الليبيه. بارك الله فيكم. شكرا دكتور محمد، شكرا دكتور ناصر، شكرا دكتور خالد، بارك الله فيكم، وشكرا لكم جميعا على مشاركتكم يعني واسئلتكم. بارك الله فيكم.
شكرا دكتور يوسف، جزاك الله
خير. شكرا محمد وخالد،
جزاكم الله خير.
شكرا.